Currently, two forms of pastoral counseling are practiced: a brief, time-limited form that is problem-solving or solution-focused, and a long-term form of psychoanalytical oriented and focuses on personality change. Clergy and other ministry personnel who have some training in pastoral care and counseling provide most of the short-term pastoral counseling. However, persons with formal supervised training in counseling and psychotherapy and who are certified and or licensed can practice what is called pastoral psychotherapy. Counseling and psychotherapy are often interchangeable terms that describe the process of helping another person make some psychological or behavioral change, typically from a less adaptive stance to a more adaptive stance. Often described as talk therapy, counseling and psychotherapy incorporate exploration of thoughts, feelings, and behavior for the purpose of helping the client solve problems or achieve a higher level of functioning. Counseling may address less psychiatrically acute conditions, such as adjustment problems, career choices, common phase of life challenges, and relationship issues. Psychotherapy is generally thought to focus more on serious personality or psychiatric disorders. Often these disorders are of longer duration or are associated with greater life impairment. Mental health professionals may focus on a wide range of interventions that are selected in light of specific clients' strengths, deficits, and symptoms. In psychotherapy, the therapist may attempt to change maladaptive patterns, improve interpersonal skills, resolve conflicts among various motives, modify irrational or dysfunctional beliefs, reduce problematic or self-defeating emotional responses, enhance or integrate a cohesive sense of identity, or facilitate mood change. There are a variety of popular mental health modalities. Behavioral therapy came to prominence in the mental health field in the 1960s. It is rooted in the work of prominent learning theorists such as Ivan Pavlov and B.F. Skinner. Behaviorists used chain techniques based on research with animals and humans and used such established learning principles as reinforcement, positive or negative, and punishment, extinction, or what's called weakening a behavior through non-enforcement, and counter-conditioning, which is substituting one behavior for another. Behavior therapy has the advantage of precise treatment goals. In other words, specific changes in problematic behaviors. Behavioral therapy is scientifically supported treatment. It's counseling that is relatively brief and is at a reduced expense compared with many other therapy modalities. Behavioral therapy may be especially helpful for anxiety-based problems in adults and behavior problems in children. Disorders as wide-ranging as phobias, tantrums, bedwetting, panic attacks are all likely candidates for behavioral techniques. Cognitive behavioral therapies are among the most frequently employed by mental health professionals today. This group of therapies emphasize both the behavioral interventions previously discussed and the powerful effects of thoughts and beliefs on behavior and emotion. Therapy in cognitive behavioral framework involves a collaborative agreement between the client and therapist on the problems to be addressed, followed by an application of a range of techniques designed to change distorted or false core beliefs. These may be beliefs about events, oneself, or other people. Cognitive behavioral therapies are generally problem-focused, brief, and quite effective for problems from anxiety to anger to depression. Humanistic psychotherapies, sometimes known as client-centered psychotherapists, emphasize helping a client grow and self-actualize as opposed to helping him or her overcome symptoms or disorders. Client-centered therapists tend to view human beings as essentially good and simply in need of encouragement to fulfill innate potential. Maslow is famous for the idea of self-actualization, the notion that when basic needs are met, people are supported and encouraged, they can achieve their full potential. Unless the typical person is excessively stressed, discounted, or otherwise blocked from doing so, he or she will generally tend to choose pathways towards personal growth and self-actualization. Client-centered therapists tend to be gentle and caring for clients, but not especially focused on targeting specific symptoms or even making a precise diagnosis. This may be an especially useful modality for clients whose primary struggle is with loss, poor self-esteem, or shame resulting from harsh self-criticism. When parishioners approach the minister with a personal concern or request for counseling, quite often the problem will relate directly or indirectly to marital dissatisfaction or distress. In fact, counseling for couples who are married, planning marriage, or considering termination of marriage may be one of the most frequent counseling activities of all ministers. Marital therapy will typically address meeting each partner's needs in the relationship. Active, clear, and respectful communication, forgiveness, enhanced sensitivity to one partner's perspective, taking responsibility for one's own contribution to the marital dysfunction, frustration tolerance, and modification of unreasonable expectations. Not surprisingly, a couple's commitment to the marriage is one of the strongest predictors of treatment success. Although there are many types of family therapy, structural family therapy is one of the most common and most promising approaches. This approach assumes that the family is a more powerful determinant of psychological disorder than individual personality styles or conflicts. Family therapists are likely to attempt structural change, that is, change the way the family is organized. This often involves eliminating problematic subsystems and shoring up poor boundaries. There are 5 categories of psychotropic medications: antidepressant, anti-anxiety, mood stabilizing, antipsychotic, and stimulant medications. Only physicians with an MD or DO degrees may prescribe medication. Ideally, psychiatric medication will be managed by a psychiatrist or a physician with considerable experience and training in psychiatric medications. This is particularly important when the parishioner has a serious psychiatric disorder, or when his or her age or other medical problems or other medications make prescribing more complicated. It is not uncommon for people undergoing psychiatric treatment to be placed on more than one type of medication in order to optimize the therapeutic value and control the side effects. At times, a parishioner may require the most restrictive treatment, the psychiatric hospital. Inpatient psychiatric facilities range from small, upscale private hospitals, which are the most expensive, to large state mental hospitals, which are the least expensive. For the most part, a mental health professional will not be inclined to hospitalize a parishioner whom you referred for treatment unless the person's level of impairment is so severe that he or she cannot function well enough to adequately care for him or herself. Mental health professionals may be legally obligated to pursue hospitalization for clients who present a clear danger to themselves, which would be suicidal, or a danger to others, which would be homicidal. In addition, some psychiatric disorders are so acute in nature that treating them effectively may hinge on having the person in a closed environment where treatment can be comprehensive and quite intensive. It is a good idea for ministers to be familiar with at least one psychiatrist with admitting privileges to a local psychiatric facility. Findings from psychotherapy outcome research seem to support a cautious optimism regarding the effectiveness and efficacy of psychotherapy. As a general rule, parishioners who are distressed or show evidence of any psychological disorder are likely to improve with psychotherapy delivered by a competent mental health professional. They are also likely to be reasonably satisfied with that level of care. Pastoral psychotherapy is defined in various ways, but it tends to involve longer-term therapy and in some instances is difficult to distinguish from general psychotherapy. While in the past, pastoral care and pastoral counseling were often used synonymously, today they are distinguished as being different. Ministers who aspire to work with mentally ill people as part of their healing team will soon realize that psychiatry is not a one-size-fits-all proposition. Scarcely two people are alike in their symptoms, illness, and response to different treatments. Most severely ill patients will be offered medication, hospitalization, or intensive outpatient treatment, and some forms of psychotherapy. Family involvement is usually encouraged, but often the family, if any remains, does not wish to participate. Activities such as various forms of crafts and physical therapy are used as evaluative tools to assess progress in mental health treatment, and also as a restorative aid in the return of normal routines of life. The most severely ill may require multiple medications, close supervision, and protective housing. The pastoral counselor should endeavor first to understand the nature of the person's illness and the problematic signs, symptoms, and behaviors the mental health professional is trying to treat. The pastor then should become aware of the treatment plan, at least in a general way, and only then should ask, what can I do to provide counsel, enlightenment, hope, support, or a spiritual intervention that is consistent with the specific needs of this patient and within the treatment plan devised by the mental health professional. If the pastoral counselor truly operates in this way, basing their administrations on the specific needs of the patient and the specific plans of the mental health provider, the pastoral counselor can provide wonderfully meaningful and perhaps life-changing pastoral interventions. These pastoral works can take many forms, including scriptural guidance, sacramental services, and restorative pastoral counseling. Using these and other spiritual tools in a highly specific way for each individual patient, the pastoral counselor will see that they can quickly become an accepted, valued agent of the change in the recovery process of a client. The recovery process for mental illness is seldom instantaneous. It is normally a prolonged struggle to find healthier thinking, attitudes, emotions, and behaviors. In treatment, the search for the better way is aided and guided by many helpers and links in the chain of recovery. Each link contributes a small but important share. The pastoral counselor should remember this analogy and work diligently to see that their work is strongly, knowledgeably, and responsibly forged.